All right, everyone. Well, thank you so much for joining today for our second webinar from Dr. Michael Lauzardo. I really appreciate everybody's participation, particularly those of Dr. Lauzardo. We'll get started in a minute, just some logistics. I appreciate the questions that were submitted in advance. And you also have the opportunity to submit questions using the Q&A function. Please feel free to enter those in at any time, and I'll be moderating those with Dr. Lauzardo. But first, we're going to dive right in with some introductory remarks. I don't think I need to make a long introduction of Dr. Lauzardo. He's one of the most famous people at UF at the moment. He's Associate Professor of Medicine, Deputy Director of the Emerging Pathogens Institute, and Director of UF Screen Test and Protect Program. And so, Dr. Lauzardo, I'll hand it over to you for some comments on how we're doing so far in the fall semester.
Great. Thanks so much, Rob. I really appreciate it. And yeah, so let's just go ahead and dive in. I think I just wanted to kind of start with some comments in the big picture, then kind of talk about where things are on campus, and then started addressing your questions. So overall, I think that the situation coronavirus-wise nationwide and just where we are with the epidemic, I don't think there's any surprises at the moment. There were some mathematical models and sort of historical models that indicated that September, October was going to be concerning for a variety of reasons. I think largely the one that drove a lot of opinion, and I have to admit I was influenced by as well, is that the 1918 epidemic kind of showed a very similar pattern where you had an early spring rise, March and April, with the incidence of cases, a little bit of quiet over the summer, and then come fall, the biggest spike that was experienced during the 1918 pandemic, and then some bumps, a midwinter spike that was much smaller, and then you kind of trickle through till you get to the subsequent summer. So overall, an 18-month course. And that seems to be what's happening, although it's far more complicated than a quick description like that could do justice to. I think also in terms of some developments that are kind of out there now is that nationwide we've been in a low over the latter part of the summer. August was good to most communities around the country in terms of COVID. Now some of the challenges are is that now that different activities and different things have opened up, there's an increase in cases. And again, subsequently, that could be followed by an increase in hospitalizations and increase in mortality or increase in deaths that might occur as we go along. Again, this is one of the things that has been one of my points that I try to make, is that from the very beginning in the initial phases of the pandemic, things were kind of phrased in a very simple yes or no, open, closed, health versus wealth kind of a context. And that sort of polarization that fits, unfortunately, all too well with where society is right now, didn't do us justice. In a lot of ways, that was kind of a false choice. There was always this idea that you open, there's a cost, how much do you open, how do you open, where do you open? And that really, there's gonna be a series of very difficult choices, not just for societies as a whole, but institutions, communities, and individuals are gonna have to struggle with those individual choices. And I think that'll continue until we get through to the other side of the pandemic. The good news is that I think there are encouraging signs. I think we're learning more. We learn more about how the effectiveness of masks. Mask usage is up. Some of the mathematical models are off because human behavior is kind of indicating and kind of pivoting in a different direction. So people are wearing masks more often. And that seems to be giving us some good evidence of how things can actually work. I think we will see an increase in cases here in the not too distant future that'll go nationwide. But again, that's no cause for dismay. There are things that can be taken to take that into account. And the promise of a vaccine, I know there's some questions related to vaccines, and I'll save those for later, but the promise of a vaccine seems to be more and more real with each passing day. Although the time frame may not be what is advertised and what people might hope it to be, but clearly there's evidence that vaccines are going to be on the forefront here, not in the not too distant future. In terms of what's going on at UF, with the opening, we had anticipated that September would be bad for us because just having 50,000 20-something-year-olds come back into town and opening up activities on campus, it was expected that there would be an increase in cases. We prepared for that. Again, and remember that expecting, accepting are two different things. So we didn't want these cases to happen, but they did, and we responded in kind. So in other words, our contact tracing team that's been in place since May in strength has done really well. We had an exponential increase in cases for about the first week to 10 days of class. We plateaued with very aggressive isolation and quarantine practices, identifying as many cases as we could. We really expanded testing, and I'll talk a little bit about that more throughout the question and answer period. But through that, we showed very clearly that contact tracing works. So it's not, the trend's been going for about 6-7 days now, but not only did we plateau our cases after that initial exponential increase after about 7 to 10 days, is that we've been exponentially decreasing over the last 3 to 4 days now, and plateaued about 7 days ago or 8 days ago. So this is all good news. The things that we have in place work. The important things to remember are that these were things related to activities not on campus. So in other words, more social activities off of campus, some social activities on campus, but in terms of classrooms, research, and the service sort of components of our mission, those weren't where the problem was. And again, I don't want to get into the kind of role that some institutions outside of ours have gotten into with sort of vilifying an age group and blaming students for X, Y, and Z. Students have done a great job for the most part. There are some outliers, and those kind of drove some of the epidemic problems that we had, and they're being dealt with student affairs and other things that are in place. But overall, students have done well, and faculty and staff have done really well throughout this surge. And I think at some point, when this is all said and done, the fantastic team of investigators that Journey Shapiro has been able to put together, a fantastic team has really kind of done heroic work to kind of, stem the epidemic. And this is the way it's supposed to work and move forward. So I think that I'm encouraged of where things are. We're putting in some new tools and new things in place to help us even more. So we've been working really hard to increase testing capacity. We're up to about 1,000 tests a day right now. That will hopefully increase within the next couple of weeks to close to 2,000 tests per day. That's not including the clinical tests that we're doing. Right now, we're targeting the places where we've had cases and some outbreaks, not surprisingly at residence halls and Greek housing. We've tested there aggressively, or continuing to do so, and go in there and test an entire area to get the contacts, get any symptomatics, and then also do the regular surveillance testing as well. Since I think we last met in this forum, the last IFAS town hall that we had, we've also kicked in our wastewater epidemiology monitoring. So we're monitoring campus by looking at the sewers, sorry about that, little Freudian slip there, but looking in the sewers and actually finding positives where we would expect, and also not finding them where we don't want to find it. So again, that process is now in place as well. Probably the biggest development that's really helped us a lot is that we just finished validating saliva-based testing. So no longer is the nasal swab the only option you have to be able to get tested for COVID-19. We've now validated saliva testing and have rolled that out this past weekend. Did 250 on Saturday, did like almost 250 yesterday, and are scheduled to do another 300 this afternoon at the O-Dome. So that monitoring all kind of comes in. We're monitoring things closely. Our disease investigators are working tirelessly to get everything checked. Again, the surge was difficult. We went through a few difficult days there with a lot of the information and misinformation that was out there. There were a few things that we could have done better in terms of advertising how to get tested and where to get tested, but we've pivoted and learned that. And then also working with student affairs, they've done a better job with helping people get isolated and quarantined appropriately. So again, far from perfect, but we're in a much better place right now and actually in a really good trajectory. This is far from over. We're gonna have more peaks and valleys between now and the end of all of COVID, but we're encouraged by going through what I think is probably gonna be the roughest patch and have done pretty well. So far, to our knowledge, we monitor this daily. I haven't looked yet today. No hospitalizations that we're aware of on our side of things in terms of the UF community. Given our sheer size, that's likely to happen, but not clearly going to be related to something that happens on campus, but we're monitoring it nonetheless. There's other activity going on in Alachua County and in the air and throughout Florida that has nothing to do with us, obviously, and that's going to start to drive the epidemic as well. So expect to see an increase in cases in Florida in the next couple of weeks. Expect to see increased hospitalizations in our hospital and others in the next 2 to 3 weeks. But that's not unexpected, and we're prepared to handle that, and we'll continue to adjust as we go along. So with that sort of intro there, I'd be glad to take any questions, Rob, that you see fit, and any that you all have. I'd be glad to answer any of those questions.
Thanks. Thanks, Michael. Really appreciate that. So let's start with the testing piece. A couple of questions are going together here. One that came in online. Could you go into more detail about how the increased recently available testing on demand will function for faculty and staff? And a corollary question is, how often should faculty and staff get tested when they have no symptoms? So the email you sent out, when should people, should they be coming in, and how will that work for them?
Yeah, great question. And some of the messaging was a little bit off. So people, we had a lot of feedback. It was yesterday, and then, it was yesterday when we got feedback that said, is UF requiring a second test, and do I need to get tested now if I don't have any symptoms and haven't been in contact with anyone? The questionnaire, we linked a lot of the different IT systems to that questionnaire. So from a technical standpoint, it's a very good tool for us to be able to efficiently order testing. So we like using that as we do, because it really coordinates things very well and allows us to make sure everything falls in the right bucket. In terms of the other piece of the questionnaire is that we want to make sure we get symptomatics. Again, even though asymptomatics can transmit, and that is a significant component of what happens, we found from our data in particular, about 77% of our cases are symptomatic. So we obviously want to go fishing there first for any cases, make sure anybody who has symptoms kind of puts themselves in isolation, has easy access to a test. And this questionnaire that went out recently was just one more attempt to facilitate that as much as possible. Now, in terms of faculty and staff, how often folks should get tested, I think that what we're trying to do is to do recurrent testing for those that are in the higher risk groups. So in other words, we're actually calculating statistically to see where the prevalence is higher in sort of what flavor UF person you are. And we're trying to break that up into research only, clinical only, Greek life in residence, residence hall, face-to-face student, and breaking up all these different flavors and then calculating kind of an odds ratio to each category and then deciding where people need to get regularly tested. So we're in the process of kind of working through that. But to answer that very specific question about faculty and staff is that if you're not a contact and don't have symptoms, we're not recommending that faculty and staff get routinely tested at this time. Faculty and staff have not been high risk. It's not been a disproportionate number of cases. Those faculty and staff that are on campus are not at particular risk to being on campus as best we can tell from the data that we've got. We're not identifying any clusters in the face-to-face folks, the research folks. We do get some in the clinical aspects, but those are usually associated, surprisingly, not with breaches in PPE, but with sort of socializing with people outside of that context and therefore getting at risk for that reason. So in general, no routine testing unless you have one of those risk factors. If you do want to get tested for peace of mind or for other reasons, we make that available as well, but really trying to focus on the higher risk groups for routine regular testing, and then contacts as well to get in there. But also all symptomatics, we want you to get tested right away.
Okay, thank you. As you're aware, Michael, IFAS is located throughout the state at research centers in every county, extension faculty. And so what about if you're not in Gainesville? What are the options for those that are off campus? Has that changed at all in the last month or so?
Yeah, and that's probably the biggest thing that, to be honest with you, I'll just be fully transparent here. That's probably been one of my biggest disappointments, is that I feel like, IFAS is kind of like I'm treating you like the cross-eyed stepchild, right? So our services that we can provide you because of distance are more challenging. Risks might be different by nature of what you do, a lot more outdoors, but you're also, depending on where you are, particularly those in South Florida, are going to be in communities at much higher risk in terms of incidence of disease, and also might be working with some higher risk populations as well. You can always call the Screen Test and Protect number if there's a question about a specific instance or requirement of what goes on. Most health departments right now actually throughout the state have pretty good turnaround times. The state, since we last had the conversation, the state's testing capacity at the Jacksonville State Lab has improved significantly. So getting tested at a state lab, at a State Department of Health testing site is strongly preferred over like CVS or LabCorp. Those tend to be a lot longer turnaround time. If there's concern over an exposure at a IFAS site outside of Gainesville, certainly let us know. And if there are increased cases, if you guys can be our eyes and ears, if there's something that concerns you, let us know. We'll investigate and make sure that we can provide services that are tailored for all of you. Again, because of the distribution, kind of some of where the places are, the nature of the work that you do, it doesn't necessarily put you at high risk, but some of you will be. I've learned through the sort of return to work program, it's just how diverse IFAS really is, the different activities and roles that IFAS plays. So I want to be very careful about some broad statements, but just always know that just give us a call and always feel free to email or text me, and then I'll try to get you an answer wherever you're at. Again, wish we could service you as much as and easily as we do on main campus, but that's something that you can still reach out to us and we'll be there for you.
And a related question specifically, so this is from someone who's at our Mid-Florida Research and Education Center in Apopka, which is driving distance away. Can they drive into Gainesville and be tested or arrange for testing here?
Yeah, absolutely. Yeah, so if you should be able to go on to the 1.uf.edu site and drive into Gainesville to get tested if you had a concern. And if you're concerned about a workplace exposure and that's why you're getting tested, let us know, and then we can see what else we can do to facilitate that.
Okay, excellent, thank you. Questions now about some policies involved. So this question is regarding the UF mask policy. If someone's traveling on business travel to a non-UF location, should they still wear a mask? And is that our policy? And then should they quarantine themselves upon returning to their home location after they do that?
Yeah, so some very good questions that kind of move a lot. So in terms of traveling, if you're in your car by yourself, you don't need to wear a mask. If you're outdoors by yourself, you don't need to wear a mask. If you're traveling in a car with other people that you don't normally quarantine with, I would recommend wearing the mask in that circumstance because it's an enclosed space. If you don't want to wear the mask, windows open would help. So that's certainly, the exchange of air makes that less likely, but mask usage whenever you're in a vehicle is what's generally recommended. To the question related to after traveling, should you quarantine after you get back? That's a good question, but just kind of bear in mind, I looked at it yesterday, if Florida were a country we've dropped, we would only be the 8th most highest incidence country in the world in terms of incidence and total number of cases. So traveling out of Florida might actually reduce your risk. Being in a plane, kind of traveling, and those enclosed spaces by themselves carry their own attendant risk with that. And I would recommend wearing a mask during those times and avoid any unnecessary travel for that reason. But most places around the world have lower incidence than Florida does, to be honest with you. So again, the idea of quarantining when you come back, there's no mandate for that. We follow what the state guidelines are, and currently my understanding is that the governor's executive order with regard to travel and quarantine is not in place right now. Some international travel might change depending on what goes on in those circumstances, but we can look up what the current recommendations are and then go from there.
Okay, thanks. Regarding facial coverings, there's been some news lately about the types you should use, and the question is, are neck scarves, for example, one from the UF branded site, acceptable to use in off-campus locations? Are they as safe as the surgical masks that you would also use?
Yeah, so again, that's another been an area of point of contention. So I think that what we've tried to do is to have our face coverings and mask guidelines match CDC's as much as possible. In general, what's recommended the most is either going to be a cloth mask that's going to have 2 to 3 layers of cloth, or a surgical mask or medical grade mask, similar to, if you can see it, it's not really showing up too well, but just the ear loop masks that you have available at a lot of our sites. Then I have my cousins made me a lot of masks that are cloth masks that are multi-layer fabric, and that should be adequate as it is. In terms of the neck scarves or gaiters, there's been some debate in the medical literature of how effective those are. If no other mask can be worn, that's better than nothing. It is not the preferred, so bandanas and neck scarves are not the first choice and not recommended. There's been some debate with the executive team and the medical advisory committee regarding those, but in general, they're not recommended. Prefer to have the ear loop mask or 3-layered cloth mask is what's preferred to be consistent with CDC guidance. N95s or KN95s are not necessarily recommended, or they're not recommended in non-medical settings. It's not wrong to wear them, it just may become cumbersome to be able to do that.
Okay, good. So the next question I have is a fill-in-the-blank question, which are normally easy, but this one's a little bit harder, I think.
Okay.
Blank has not been going as well as planned.
Oh, good question. I like that. Yeah, can I give you more than one?
Sure.
Yeah, I mean, just to be fully honest, I think that, the first call I made when I was asked to coordinate screen test and protect was to communications, because I knew from experience in public health, communication was going to be critical. I think the communications team has been fantastic. Again, I've really enjoyed working with strategic communications, with the Health Science Center team. They've been fantastic. But the extent and the amount and the speed with which we need to communicate, I underestimated. And I think we all did to some extent. So you can't do enough of it. So I think the communication, I wish we could have done better. And we're still trying to get that better. I think it's improved, and we're still getting that better. The other thing too is that I probably, along those same lines, instructions about what to expect, I think needed to be, I underestimated how powerful the infodemic, as I like to call it, the bad information that's out there, how fast bad news travels and wrong news travels. I underestimated that. So in other words, right in the middle of the spike, students could get tested. They just didn't know how. And we didn't really kind of convey that enough. We'd said when they came on campus, you can fill out the questionnaire, save the email, you can go back and click on it later and get your test whenever you want. That went out the window, and then there became this culture and this idea that no testing was available on campus. So we had people driving, literally 2 hours, 3 hours away to try to get a test when we had them available here. So another kind of miscommunication on my part, to be honest. I guess I'm ultimately responsible for being able to communicate that. So I think we fixed that. I think those are the two biggest ones that I think have not gone as well. Yeah, and I think also just from the very beginning, I think also again, getting back to communication, communicating to people that let's not buy into sort of the polarized kind of dichotomous view, right? It's either this or that. It's like, this is hard. This is difficult for all of us, and that it's there are benefits and risks to everything that we do, and just pulling people together more on that concept and that idea. I think we're there. I think we've been able to convey that really important message, but it came at a higher cost than maybe had we kind of come out of the blocks like that back in March. So that's the other piece that I think I would have liked to have been able to change, have go differently.
Thanks. I think you made a couple of statements I'd like to emphasize too in terms of what's going well. I believe you said, Michael, that there are not many or maybe any documented cases of workplace transmission, nor I think you said have there been UF folks hospitalized. Is that correct?
To my knowledge, now it's certainly possible that people can get hospitalized somewhere else. We've got folks that we know over in North Florida that we're not hearing anybody that's hospitalized there. We check our daily census here at UF to see what's going on. I'm not saying that's never going to happen, and I'm not saying that when it happens, it's our bad. Obviously we're in a community and it's a pandemic. I'd be shocked if that doesn't happen. So I want to get people prepared to accept that unfortunate reality. But it's just, from activities based here and the clusters that we can analyze here, it's like, we're not there. And so one of the things that we've done since our last meeting too is again, things move kind of slow, but we're working to get our IRB approval so that we can do a lot of in-depth molecular analysis of the viral spread when we do get clusters. So sequencing the virus, linking it to the epidemiologic data. It's going to be an exempt protocol, I'm certain, because it's public health practice, but again, it just takes time to get that in place. But that'll help us really know, yeah, we've got 3 cases in this classroom, say hypothetically, but they're not linked because the genomes don't match when we do the DNA or the RNA fingerprinting to the virus to see if it's part of a true cluster, if they really connected to each other or not. So that's going to be an important thing that we do. That's kind of the next phase that we're kind of working towards. We've been kind of in urgent, get the job done kind of mode here, dealing with getting ready for the start of school and the surge. And I think we're still busy, and we're still plenty busy. But I think now we're kind of shifting to, quite honestly, to go from defense to go to offense and start understanding this a little bit better, generate some knowledge, and then keep having it inform our practice.
Okay. Thanks. And I'd also just like to make a comment that it's a real tribute to all of those of you that are listening and those around the state that have worked so hard to keep your workplace safe and get your work done at the same time. So thank you for all the work you're doing on that. And I think we're showing the results of that through the statements that Michael just made. Some questions of epidemiology now, please. Question on surface transmission. I think the consensus is that surface transmission might not be as dangerous as first thought. What's the data and research behind that, Michael?
Yeah, so I can't quote the papers off the top of my head. I should kind of keep those because I get asked that question pretty frequently, but there's less and less evidence that it's related to touch and from just fomite spread, as we call it, in sort of infectious disease and in public health. So in other words, someone coughs, like I'm looking at my little desk here in front of me, and wherever I touch, I can see there's little droplets. If I'm infected, someone touches that, they rub their eye, pick their nose, touch their mouth, eat with infected hands, that's how you get spread. That's probably not that important. It's important. Now, my hands are dried out and chafed from so much that I've been washing them. However, that's probably not the main modality. CDC's official guidance has been that it's respiratory droplets. So in other words, the droplets that make those spots on the table, I'm spitting into someone's eye or into their mouth, or that then I get on them. That spreads that way. So that's the 6 feet of physical distancing, social distancing that we've got there. But there are many of us who are convinced that aerosol is probably the most important manner, right? So all of these play a role, fomite, respiratory droplets, but it's the droplet nuclei. So in other words, those small invisible particles that actually float on currents of air that don't travel ballistically. So in other words, they don't go out of my mouth and then land by gravity. It's the things you can't see that kind of float in an indoor space over a long period of time with high concentration. Masks reduce that. They don't eliminate that, but they come pretty darn close if both the infected person and uninfected person are both wearing a mask. If they're physically distanced, that helps because the aerosol is going to be greater in the immediate space around a person, especially indoors where there's not a breeze moving the air around, a lot of air movement. But that's probably the bigger risk. And you may have heard there been editorials written about this. Our team actually published a paper showing that aerosol is possible and getting viable virus from the air to match a patient has been done for the first time. And so I think that's where things are going. You may have even heard over the weekend, CDC changed their guidance to say there was aerosol, and then they pulled it because they said it was just a draft. So again, there's a lot that's out there, but really essentially the detoxifying the environment, coming in and cleaning, all that stuff is probably nowhere near as important as we thought. And so the precautions that you take post-COVID infected person are probably much less than our even current guidelines suggest.
Thank you, Michael. A couple of questions on vaccines. There was one in the chat saying, is UF making our own vaccine? And I guess the answer to that is no.
That would be no, yes.
Right, but what would you like to share about progress on the vaccines? There's been this debate about, are we rushing too fast versus, can we get them out soon enough? And what these new types, will they be safe to take when they come out? What are your thoughts on that, please? Yeah,
all great questions. And one thing too, I was just going to say that I'll kind of, you guys will hear it first here, but I will pass this along to the executive and kind of make sure that it kind of fits in everywhere, because it's to kind of undo one of those things that I wish had gone differently, that we had things aligned from the very beginning. But UF is very fortunate to have one of our faculty members, Sonia Rasmussen, who's a member, who's on a National Academy of Sciences committee on vaccine access that has been convened and has written a draft document that's being revised that will eventually guide probably national policy in terms of who gets the vaccine and when and what the precautions and considerations are. So expect to hear more from Sonia in the coming months as vaccine becomes more of a reality and there's more data that comes behind. So Sonia we'll be working with Sonia, and she's a faculty member in the College of Public Health and Health Professions, longtime CDC employee, and kind of rose through the ranks there and very well known. So Sonia will be giving a lot of information about that. But in the meantime, right now, in terms of vaccines, you're going to see some things we've never witnessed before, which is going to be issues related to vaccine nationalism. So in other words, the US made a very conscious decision to not be part of the WHO's process. So there are 20-something vaccines that are going through clinical trials outside the US that not a single one of us will ever get unless we're a national from another country and go to that country to get the vaccine. However, the US does have a pretty robust capacity at vaccine development, and through the current, perhaps peculiarly named Operation Warp Speed, has 8 candidate vaccines that are going through that. I think there are, of the American ones, I want to say that there are 3 that are currently in phase 3 clinical trials, either 2 that have already launched, starting enrolling on August 1st, and I think the other one just started now. And I forget which one's which, but it includes Moderna, AstraZeneca, and there's a 3rd one that I forget which one it is. And I forget.
Pfizer?
It is Pfizer. Yeah, Pfizer was starting them now. Thank you. And I forget which modalities each one of those are using. So those have been moving along nicely. The preclinical data and then also the animal studies showed a really robust immune response, and I think it was rhesus monkeys. Things are kind of heading in the right direction. The reality is that it's just going to take time. You've got, I think each arm has 30,000 enrollees, and you just need time to know if a month, 2 months, 3 months post-vaccination is enough. So even if the first person enrolled in that phase 3 trial on August 1st, 3 months is going to make it November 1st before that one person is able to say 3-month validation. There's no way you can do the analysis in that shorter period of time. So what we might see some initial data about some other trials that are there, some early information that show that it's looking safe and it's good. There are some legitimate ways in which studies can be, or vaccines can be approved earlier. But again, I think we're all aware of some of the political background and some of the suspicions that are out there in terms of the efficacy and safety of the vaccines. I think that we're going to have a very safe vaccine. I think it's going to be very difficult for us to fully subvert the safety process. I understand the concerns and I understand where people are coming from, and I share many of those concerns, but I don't think the process has been that corrupted to where that will not be able to happen. So I think we're going to have an effective vaccine that'll be effective enough. I think there are going to be multiple choices of vaccines for us to be able to get. That'll happen sometime in the spring and in big numbers. There may be something that comes out earlier for PR purposes to say, hey, look, we've got vaccine and first person's getting the vaccine, on September, what's today? September 24th. Yay, we got the first vaccine, but it's just, that's not legit. I mean, I think the real numbers and the real kind of production and the real massive testing will start sometime in the spring. It looks like healthcare workers will go first that are high risk, and not just any healthcare worker. It's going to be frontline healthcare workers, and then it'll be at-risk groups at the same time. My personal opinion is that vaccine hesitancy is going to be a thing. And so we'll probably drop down very quickly in the different recommendations groups so that it'll get to the point probably, I'm just guessing and speculating here, but probably by May, if anybody wants a vaccine, they're going to be able to get it. So it's not going to be just the higher risk groups, because I think there's going to be that desire to kind of get anybody, because there's maybe not enough people wanting to do it initially. I think that, but I will have confidence in a vaccine if it comes through. I will be one of the people that will get it early on as possible, but I want to see the data. I'm not, again, and I'm not blind to what's going on, and I want to have the confidence that we're doing the right thing. And I think it will. A lot is going to depend on the next, what happens in the next few weeks, but I think that can happen. I think from a science standpoint, the news is good. I think from a political standpoint, the news is not so good, right? So it's just, we're, for the first time ever, really have to consider these things in terms of something that would be medical. An interesting point that was just made aware to me. So Google Health, it's a great thing that they're doing. Google Health has been convening these sort of brainstorming, you can say anything kind of phone calls that they do on Sunday evenings. Been doing that for I think they've been doing about 2 or 3 months. And so on the last one that I was on, they get a number of different universities and big pharma companies, vaccine companies, researchers, different units together to kind of brainstorm and talk about things. But one thing that I found out in the last meeting is that the American vaccines are going to have a very tight cold chain requirement. So in other words, it has to be at -80 or -90 shortly before administration of the vaccine. So you can say, okay, well, that's easy. Just buy the fridge and get the dry ice and do what you need. That's true. That's going to be a big thing to scale up that many vaccines. So that by itself is a big challenge. But what the real important thing for average, citizen Sally and, Joe Public is going to be that you're probably not going to get this vaccine from your private physician. It's probably going to be at larger vaccine centers. So like at UF or larger institutions doing big numbers. So again, that might contribute to vaccine hesitancy because your private doctor's office is not going to have the -80 requirement, nor will they be able to support the supply chain to kind of get that. So those things are still being worked out. Logistically, McKesson was on the last phone call that I was with, and the president of, I think, FedEx Americas to kind of talk about the logistical challenges that they're going to face. But that's going to be an important thing. So just be prepared that when the vaccine becomes available, many of you on this call will not be first up, but that you'll probably be able to get it a little bit later on as things kind of roll through. But it's probably going to be, to be honest with you, one of our current sites on campus at UF would be my guess.
Thank you. Yeah, and I think also the guidance is that you don't necessarily get vaccinated and throw away your masks. You still will.
Correct. Yeah. This is going to take a while, right? So you're going to have to. We're going to have to stick with the mask for a while. I suspect masks will last. I'm an optimist, a hopeless optimist, but I think that we'll probably be able to move away from the universal masking sometime. I'm hoping June, early summer.
Okay. Thanks.
Hoping that, but it's going to take time. And there was also a communication that went out that talked about, the spring break, just kind of that no spring break, and that the winter break was going to be a little bit longer to allow people to get the chance to get the vaccine should one become available. That's not likely to happen. So it's unlikely that people will be getting a vaccine over Christmas break. Just wanted to clarify that confusion that might have come about.
Thanks. I have a question here about being reinfected with COVID. If you've had COVID and tested positive and recover, can one get reinfected and become symptomatic again?
Yeah, the reality is that this should be a much easier question to answer than it is. But the answer is yes, you can. The reality, though, is that it's probably not very common because we'd be seeing it a lot more by now, right? So it's been 6 months. There's a heck of a lot of COVID that's out there. And we should be seeing people that say, hey, I already had it. Why did I get it again? And I got sick, and have people get legitimate illnesses from it and not just asymptomatic infection just because of a positive test. So I think that there's some confusion related to kind of well, not confusion. There are several different things that can mask and look like reinfection. One, we know that some people have an unusual immune response to this. So when they get recurrent symptoms, are they just reacting to leftover antigen or immunologic stimulation that has nothing to do with active contagious infection now? Did they get reinfected? Or is it some other infection that's there, but they're testing positive by PCR because the RNA can last for a long time and it's not viable virus, it's just viral particles that remain and give you a positive test. So those things are still up in the air, but my personal feeling is it's, again, this isn't some sort of zombie virus, right? So this is probably very similar to coronaviruses that exist now. And we know there that you have relatively short immunity. So probably, last maybe 6 months to 2 years, somewhere in that range. It's not permanent. This may be on the short end, is 3 months is probably conservative. But you can get them again. Kids get them all the time. And that may be why kids do so well. They've got built up coronaviruses and immunity ready to kind of fight against this coronavirus as well. So again, there's a lot of questions in there, but overall, yes, you can get it again. We're probably going to have to get vaccinated on a regular schedule, get 2 shots up front, and then probably annual thereafter, similar to what we do with the flu. You can get infection again. It probably becomes more mild the second time around, but there's not a lot of data. That's conjecture and speculation on my part, but consistent with what we see with other coronaviruses. And then over time, viruses tend to kind of maybe get less virulent and sort of less toxic. So in other words, we can expect this to sort of kind of fall in line a little bit more with a little bit more benign disease in some age groups, hopefully.
Good. The question here, in the event someone has tested positive with mild symptoms and recovered, what is a recommendation for follow-up testing, and how soon does one get retested and return to work then?
Yeah, so good question. The heart of that question is, do you need to get retested ever again? The answer is no. So for the majority of people that we return to campus after infection, is that we follow CDC's guidance in terms of symptom and time-based return to work. So the average person that we see with COVID that we put into isolation has upper respiratory tract infection symptoms, so runny nose, sore throat, may or may not have a cough, body aches, kind of feel kind of crummy. They get tested, they get their result back on day 2 or day 3 since the onset of their symptoms. They're in isolation by day 3, day 4, they start to feel better, not all the way better. Their cough is starting to get better by day 4 or day 5. They may not be all the way better by day 10, but after 10 days, they can go back to work. we don't even bother retesting them at that point because the PCR can remain positive for a prolonged period of time. In March and in April, when we were testing it, some people were testing positive 2 months after the resolution of symptoms. And then with culturing, there was no evidence of viable culture in those instances. There's still some debate of what to do in the clinical setting. That's a raging debate in the hospital right now. There are many of us that think that you should just don't test, let them go back, let them go clinically. It's not gonna be any different. You're wearing masks anyway. So there's no need to retest. 10 days is usually the limit. If you're symptomatic and not getting any better, then you want to have at least 24 hours without a fever is the CDC guidance. Our guidance is 3 days without a fever, and that your respiratory symptoms have been improving for at least 1 day. And that's our guidance beyond 10 days.
Thank you. A question about the weekly survey. If someone does not have symptoms, should they select opt out or schedule for another time? They don't want as being out of compliance, but the survey wasn't clear if opting out means they were not compliant.
Yeah, so you've got several choices. One is which the language got changed in a hurry yesterday morning when we got all the feedback, and it was clear that the language wasn't right. So it's just IT speaking with medical, speaking with public health, speaking with administration. Some things kind of fell through the cracks there. We all speak a little different language. So the opt-out option will be what I would recommend now. But now, to my understanding, that language got changed yesterday or this morning to say, I do not desire a test at this time. So in other words, and also, if you don't have symptoms and if you're feeling good, you don't need to fill out the survey. The survey is just as a reminder to say, hey guys, we just want to check on symptoms and just have you take a look. And if you do have something, when you fill this out, we use that information to assess how to get you in the queue to get tested, how acute we try to get you taken care of and get tested, and get you back, out of circulation if you have any of the really concerning symptoms that allow us to then protect others around you. So we're still tweaking the survey, but I think that was there more to see how many folks that actually are having symptoms so that we can prioritize symptomatic folks over others that want to get tested.
Okay, excellent. And then there was a question about how many positive cases on campus have we had since reopening, and it is on the website, although I think they have to integrate under the curve a little bit to look at exactly the number of this. Would you like to talk about the website a bit and what information is there? And
yeah. So one of the things that hasn't gone as well, that's a good reminder, because I put it on the broad category of communication, but just truth be told and transparent here, I don't think we've done a good job with the dashboard. Even though we were ranked, we were graded a B+ on our dashboard by, actually Yale University has this service that they're now ranking and grading all the university dashboards that are out there. We got a B+. I'll tell you now, I don't feel like we have a B+. I'll just leave it at that. But if you look at that dashboard, it could be more clear. The EpiCurve will have the number of cases based on date of onset of disease that we got on each particular day. So if you hover over that, you should be able to access from the Screen Test and Protect website, and also on the UF homepage, there's a button that says COVID information and takes you straight to that. If you hover over that, you'll see the actual number of people that had the date of onset of their symptoms on that particular day. There's 3 ways to count cases. It's the number of cases that we enter into our system that we're aware of on any given day. And those people that then have date of onset of disease when we do our investigation. So that's going to shift the numbers over a little bit more. And then lastly, there's going to be the date that the actual positive test was obtained. So those are 3 different kind of ways in which we can collect that information. Now that said, if you scroll down to the bottom of that dashboard, you can actually see the total number of people that we have put in quarantine and have put in isolation total. UF has had about 3,000 cases on campus since we started counting in May. There were a few before that, but I think the start date, if I'm not mistaken, from that count is about from May when the numbers went up. We had our biggest number cases was the second week of school, and I've got the numbers behind me, but we had 752 cases in the second week of school. So we were popping at about, we peaked at 169 cases in one day. You may not see that on the website the way it is because that's date of onset of disease. I'm looking at numbers that were from the cases that we put in on any given day. So we had, if you look at the EpiCurve, you also have this exponential increase that started somewhere around September 7th, September 8th, kept going up, got to a peak at, as we count them, 169, 170 cases that we were aware of, plateaued, and now we've had an exponential decrease. So we had 30 cases on Monday this week, and we're staying below 50 for the last 3 days. and started to go down from 120 6 days ago. So we hit our plateau and then came down. And that's exactly what the mathematical models show would happen with an effective contact tracing program and isolation program in the face of a massive outbreak, which is what we experienced on campus. So it didn't continue to double every 2 days. The contact tracing worked. What people, by isolating, getting tested, we're not going to take all the credit for it. People did the right thing, and we're able to track that down. So that's kind of where it is. Now, also bear in mind that our numbers are going to be different than other universities. I'm on a roundtable for CDC next week with other giving advice about what universities have done and what's worked and what hasn't worked. Actually, it's the call's tomorrow. On that call, I told them the way that we count cases in our unique relationship with the health department, and to their knowledge, no one else is doing what we're doing. In other words, getting all the cases that come through and cross-matching them with our UF master list to see if there are cases that are identified. And if any UF person gets hit, that person's a case, and we count them, as opposed to universities, which, again, a university is not a public health entity, right? It's not a reporting unit. Health departments don't have a way to report and say, this is a UF person, this is not, this is a FSU or UCF or Emory University or whatever school. That's done internally. And whatever those numbers are, it's either tests that they do themselves or self-reports. The only way you can get what we've got is that you have to have a system where you're dually employed. Now, other universities may have that. I can't claim to have, comprehensive knowledge of what all universities are doing, but the only way you can get close to comprehensive information about cases is through the health department, because the legal requirement to report. And so with that, our numbers are big. We're in Florida where there was a lot of cases to begin with. We're a big university, so there's a lot there as well. But then in addition, our way of counting is more robust. And again, so my position has always been, I don't want to be scared of the numbers. I'm not trying to make the numbers look good. I'm trying to stop people from dying. I mean, to be quite honest with you. So again, it's just, that's really the ultimate outcome that we're looking at. So our numbers look bad, but I think in many ways they're better because it's a more comprehensive look of what's really happening.
Thank you. A couple of quick questions about the weekly survey and testing. Please confirm weekly survey is not intended for asymptomatic employees. I think I heard that. Is that correct?
That's correct. But if an asymptomatic employee says, I might have been in contact, or I'm worried that my in-laws are coming and I'm worried about them, they have a lot of risk factors, and you want to get tested, you can get tested. So you just follow that same mechanism, and there should be a way to be able to do that. And if not, then you can reach out to us and then we'll find a way to facilitate you getting tested if need be. We don't normally recommend that. We want to focus on the symptomatics and those who are contacts to cases. But again, we want to just increase access to testing throughout campus.
So a similar vein here, if someone was asymptomatic, saw the email yesterday, signed up right away, should they cancel their appointment?
Yeah, they can cancel or not show up. If they didn't understand something, they don't want to get tested, that's perfectly fine. And there's no consequence. So unlike the sort of return to campus for students and some of the things where it's a requirement to fill it out, there's no mandatory requirement for this. This is for us to make it easier to get testing and for us to understand what's going on campus in terms of symptomatics.
Right. All right, let's move on to the fascinating topic of saliva.
Oh, yes.
Yes, I never thought I'd be doing saliva questions. I think you mentioned in another meeting, Michael, that sometimes it's difficult to collect enough saliva from people. So maybe you could talk a little bit about prep for the test. The questions are the saliva test only available at the O-Dome, and will it be offered at the Phillips Center in the future in addition to the swab test? Yeah.
So great question. So yeah, I have to share your enthusiasm or lack of enthusiasm about SPIT until this time, but I'm actually super excited about SPIT and with good reason. So we were able to validate the saliva test, and that's basically a different way to collect the specimen. So in other words, it runs on the same kind of concept. It's a PCR test that the collection mode is different. There's some processing things that we validated separately. That's a different question there. But right now, the saliva test is something that we're using as an option to collect specimens from. We started testing about 2 weeks ago to validate it. We did the test in over 100 people with matched pairs of saliva with a PCR swab at the same time. I've got to talk to Jennifer Hunt at the pathology, the chair of pathology. But from what I looked at, we had 98% correlation between the two tests. And the two that were not were I think they were longer standing positives that were positive on the PCR swab, but not positive on the saliva PCR test. So in other words, there is a challenge. So part of the reason why we're not doing exclusively saliva is because it's a very different operation, right? So in other words, collection is different. The time takes more time, and you don't need trained personnel. So right now, for example, yesterday we were at the law school doing a sort of campus neighborhood testing at the law school. We had 50 people collecting saliva, spitting into their straw, physically distanced, and then just drop it off when they were done. And so they just came, pick up their packet, we tell them how to do it, they do it, we kind of make sure they do a good job, then they drop off their packet, and then they're good to go. It will be available at Hull Road at some point. Right now, we're not quite there yet because the logistics of the drive-through, and we're gonna have to kind of separate that a little bit. So this is more of an operational challenge than a science and a laboratory challenge at this point. So we will eventually offer saliva testing as an option for any site that we're doing testing for COVID-19. And we suspect that, you know, who thought spit would be so popular, that by popular demand, spit's gonna be an option wherever you go to be able to get that. And I think that's probably gonna become the dominant mode. Bear in mind that very few people, but there are some people that can't produce enough saliva. It's only 2 cc's, but some people may just say, just give me the swab instead and be done. It's 10 seconds, as unpleasant as it is. I'm not trying to advertise or sell that we keep it. We're gonna keep it, but also when flu season comes around, there are going to be people that we're going to be concerned about flu, and you cannot do saliva testing for flu or RSV or some of the other respiratory viruses. So we will keep that swab option. And if we're having a big flu outbreak, we're going to stop doing the saliva test and then probably move towards the swab for certain circumstances. So again, the swab is still going to be around. I'm in our sort of our, if, for lack of a better term, our Screen Test and Protect Command Center, and I'm surrounded by boxes that have about 3,000 swabs and about 3,000 viral transport media kits. So we're still prepared to continue to do that in big numbers, but we'll continue to keep the move towards saliva testing.
Thank you. Question about aerosol transmission, how building ventilation affects it, if UF is concerned or do anything about this, and any guidance on other public spaces in Zanesville that you would recommend or not recommend going into.
Yeah, I think that in terms of the aerosol spread, I think our finding in the hospital, and I think some of the increasing information that's coming out there, I think is generally good news. People kind of saw it as concerning. It's like, oh my gosh, it can travel 17 feet or 20 feet or 30 feet away. We're missing the point, and we're not communicating that well. That's on us, because the idea is that it just floats in the air and it's an enclosed space. So it really emphasizes the importance of an enclosed, tight space for a prolonged period of time with somebody who's sick, not wearing a mask. So in other words, what that does to me is very empowering, is because the patient room in which we did our aerosol study was unmasked, closed door, locked in, basically like a little petri dish, a little oven for COVID. So with that, we're gonna find it. And so the idea is that we can find it, identify it, and that proved the point that the virus is there. But if you're wearing a mask, the individual's wearing a mask, that chance is really, really low. And in the healthcare setting, when we go into those rooms that are really teeming with virus, swimming in virus, we don't get it when we're wearing our N95s. But again, if everybody was wearing a mask, the chance of transmission would be significantly, significantly lower. So in other words, in terms of ventilation systems and things we need to do to change, there's no real clear evidence that in the average setting that would have to happen, because you can have a you can have a student sick with COVID who's in the room, high viral load, in a regular classroom size for a brief period of time. It's not going to be dangerous if people are following the guidelines with regard to the mask. I'm not saying it's a zero chance. I'm just saying that it's a risk worth taking when you look at the benefits versus the costs and the very limited benefits, making a big change with that. So I think that's important to remember. And another point to remember is that household contacts, only 20% of household contacts, that means sleeping in the same house, in there all the time, in there probably 16 hours a day, breathing in the same air in a house, only 20% of those become infected. So just kind of bear in mind that a relatively brief classroom exposure or office exposure or spending time in a research lab, that risk is still substantially lower, especially when you add the factor of masks on top of that. So that really reduces the risk. So in other words, doing big engineering changes, a lot of physical space changes is really not indicated at this point. And we know from our studies in the hospital that transfer or spread through the air handling system and kind of going throughout the entire facility is not something that we've seen when we check the air handlers in a hospital where we know there's a lot of virus.
I guess another part of the question, Michael, and this is another corollary question that's come up, is the risk of transmission inside a restaurant or building if you take your mask off to eat or drink. I've seen pictures of folks downtown in Gainesville, lining up to go into a bar there, for example. That's probably not a good situation. So what out in the public, outside of the workplace, what are recommendations for people as they live their lives out in the public?
Yeah, I mean, I think, and this comes into those sort of difficult decisions that that I referred to earlier today, that just, it's not easy. So in other words, some people really want to go out and want to go out at a restaurant. CDC has published a paper now that showed that people are twice as likely to get infected if they report having been to a restaurant in the last week. So in other words, that's I think the odds ratio was 2 for those who had been to a restaurant in the past week when the studies were done. So in other words, going to a restaurant has its risks. Do takeout, eat at home, or eat outdoors with friends is far less risky than going into a restaurant. Does everybody get infected that goes to a restaurant? No. And so it just, what I see my job is to say, going to a restaurant has its risks, whether someone, and then I try to quantify that so people can identify and say, is it worth it or is it not? And then make their own choice. Again, it's those difficult choices from a societal standpoint. So from a public health standpoint, the answer is no, stay home. That's the way to stay safe. But what does safe mean? And what does safe mean in a context of a pandemic? And then what risks are you willing to take versus you're not willing to take? So overall, if you want to reduce your chances, don't go to a restaurant. If you're willing to take some chances and use precautions, yes, but I can't guarantee that you're not going to get infected, because this is what the data shows. I think bars in particular are much higher risk because you're not just sitting there for a little while, usually loud music, you're leaning into someone's ear and saying, hey, how are you? You're screaming 2 inches away. It's like, hey, this is a great place, isn't it? So that's kind of there, right? And it's kind of wearing a mask gets a little bit more difficult. So, and we do know from our previous studies here and then also in other sites that bars were associated with increased transmission. And so I think bars are significantly higher risk, and especially with our population on campus, that's going to be an even bigger issue. So I think the next bump that we're going to see will be related to that. Now, that said, I don't want to cast bar owners as bad guys. These are small business owners who are doing an honest business and just need to had the misfortune of having something pop up that really hit them really hard. My personal opinion is that there's CARES money to support small businesses that are hit disproportionately. And I would say, pay them to not be open. I think to somehow support them because they need our support. I don't want to villainize them or vilify them. It's just, this is kind of it's just reality. But I think bars are higher risk than restaurants, and there's data to support that. And, but both are legal and both are open, and it's up to people to assess the risk for themselves, whether or not they want to patronize them. You're much better off outdoors. And if you can be outdoors, do so. But that by itself is not a guarantee, but I strongly recommend if you're going to do either one of those to do it outside.
Quick question here on vaccines. When they're offered, will you have offered the vaccines to the staff or faculty or students' family as well as the employee?
Yeah, I don't know the answer to that. I think a lot of it's going to be determined, the policy will be determined by how much uptake there is of the vaccine and how effective it is. So again, there'll be a calculation. If it's a 70 or 80% effective vaccine, which is maybe not likely, but let's just say for argument's sake, it's 80% effective. You may not need to vaccinate as many people to be able to get sufficient herd immunity. And therefore vaccine hesitancy may not have such a big impact. Also, the safety data may be overwhelmingly convincing, and it may be the best thing since sliced bread. So everybody that's required to take it will, and so they'll limit who it will go to, and then you'll be able to get the vaccine later in the fall of 21 rather than the spring of 21 when you come to lower risk people further down the list in terms of their overall risk. But again, this is going to be a somewhat fluid situation based on vaccine efficacy, vaccine hesitancy, yeah, I guess those would be the two biggest ones. And also background immunity as well is probably going to play some role in that decision.
Well, we're almost out of time. One of these, the final thing I'll mention is a question in the comment here. What are you doing to personally refresh and recharge? This is certainly a war and not a battle, and we're fortunate to have you as our local COVID commander-in-chief. So here. to that. And so we want to make sure that you stay healthy as well, Michael.
Well, I really appreciate that. And that's very encouraging. What I tell people somewhat tongue in cheek is that I really do appreciate those comments and that encouragement. That keeps me going. But I really hope you say that in June. And it's not like, God, Lauzardo guy screwed everything up. Where did he go? He got fired. When did he get fired? Was that January or March? When did he get rid of, when did we finally get rid of him? So I'm hoping you guys still say that in June. But I do try to take care of myself. My wife makes sure that I try to do that. It is a war. It's a long battle. I've never been so exhausted or energized at the same time by something. So I've been this tired before. I've been this excited before, but never at the same time. And I think it's just, I'm trying to project to, 5-10 years from now, what do I want to look back and remember as far as like what we were able to do. And I think try to remember that every day. So I appreciate the encouragement, and, I just hope everybody keeps taking care of themselves, and appreciate your questions.
Well, we've come to the end of our time. Thank you so much, Dr. Lauzardo, for all that you're doing for us and everyone at UF. And I'm sure if you're willing, we'd love to schedule you again in a few months with further questions from everyone. So thanks, everyone. Stay safe, everyone out there. Thank you so much.
Yeah, I appreciate it. Thank you very much. Y'all have a great day. Thank you so much.